Hello everyone, welcome to HIM 216. This is a continuation of the lectures for Chapter 8 in your textbook, and this is the 7th lecture for this chapter. In your textbook we're on page 156, and we're going to be looking at the root operations related to bypass, dilatation, occlusion, and restriction. So in your textbook on page 99, you will see these. It's the second grouping there. These are root operations that alter the diameter or route of a tubular body part. And we'll also work more with these when we are in specific chapters, particularly when we're in the circulatory chapter and we're looking at coronary artery bypass graftings. Now your book tells you that when we have a root operation of bypass, that this is when we actually alter the route of the passage of the contents of a body part. So think about a coronary artery bypass graft. When what we're literally doing is bypassing arteries that are blocked and providing a new route for the blood in the heart. In your textbook, if you will look on page 390, you will see figure 1622. And this is an example of what a bypass looks like. Bypasses are typically called aortocoronary artery bypass grafts because the graft originates in the aorta and then it bypasses the blockage on the artery. So when you look at this picture, you can see they took vein from the patient's leg and they took the saphenous vein and they attached it to the aorta, and then they went down and you can see where the figure shows you blockage in a coronary artery, and that bypass actually went to that blocked coronary artery, past the blockage, and attached the vein from the leg. So literally the heart can continue to receive blood through that coronary artery via the bypass graft. And when you look at figure B, again, this is an artery bypass graft. This material came from the chest, and they use different materials, but that's what a coronary artery looks like. When a patient has gastric bypass surgery for weight loss, they are bypassing the stomach. So that's another type of bypass procedure. So your book tells you that for the most part we have to identify the body part that was bypassed from and the body part that was bypassed to. It tells you that another way to look at this is that the contents of the body part is being rerouted in a downward stream. There may also be procedures that reroute the contents to a totally different area of the body. And an example of this is cerebrospinal fluid from the brain. They use what they call a ventriculoperitoneal shunt, and that fluid is bypassed into the peritoneum and then absorbed into the body. So think about a baby that has maybe a very old term water brain. For some reason the fluid in the brain isn't being evacuated in the normal manner, and they have to go in and put in a shunt. And this happens to adults as well. Another example of a bypass is the creation of a colostomy. So other procedures are like the CABG, a gastric bypass. There is a femoral popliteal artery bypass. This is called a FemPop. And then sometimes there will be urinary diversion of the ileal conduit. So I would suggest that you spend some time, research those procedures on the internet and see what they involved. So let's look at this first example of a bypass. And this is insertion of ventriculoperitoneal shunt via an open approach. And this is happening in the brain. In the index, I'm going to put in bypass, and we are bypassing the cerebral ventricle. That's what this says. Cerebral, it's a ventriculoperitoneal shunt, and what we're bypassing is the cerebral ventricles. And when we look at this in the index, we know that our approach is open, and we are choosing the option for synthetic substitute. Now, your options here are autologous and non-autologous tissue, but typically a synthetic substitute is used, and that would be very well defined in the actual operative report. And the bypass 2 is going to be the peritoneal cavity. So we went from the ventricle, the cerebral ventricle and ventriculoperitoneal, and we went to the peritoneal cavity. So that is how we got to that code. Again, I think this is a note card opportunity. Now, according to I-10, the coronary bypass procedures are coded differently from other procedures. The body part identifies the number of coronary artery sites bypassed to, and then the qualifier tells us what vessel the bypassed from. The bypassed from is the vessel. The most common type of bypass is from an aorta to a coronary artery. So we're going to go back to bypass, and then if we look at artery and then coronary, we can see that this is broken down just like the guidelines tell us by the number of arteries. Well, I'm going to pick 1. These all take us to the same 0, 2, 1 table. And you can see that if one artery is bypassed, we have a specific character for that. 1 for 2, 1 for 3, and then 4 or more. And of course, we choose the approach. And the device is based on what type of tissue we're using. Are we using vein autologous, means from the patient? Are we using material venous tissue from the patient or arterial tissue from the patient? We'll spend more time on this when we're in chapter 9, but this could be saphenous vein from the leg. This could be a mammary artery from the chest. I'm just going to choose venous tissue, and then the qualifier would typically be the aorta, because that's where we're going from the aorta using the autologous venous tissue. If I choose autologous arterial tissue, I could be actually just taking down an internal mammary, or I could be harvesting it and going from the aorta. So it takes reading those operative notes and understanding those procedures to assign these codes. If we look at this example of a CABG, this was 3 coronary arteries. They used the greater saphenous in the vein, and it was harvested with an endoscopic approach. So for this, because all 3 of these bypasses used the same material, which was the saphenous, we can choose coronary artery 3 coronary arteries. If they use different material, we would have to be coding them separately. Our approach is going to be open. We know that it's autologous venous tissue, and it is from the aorta. So our code is 021 209W for the actual cabbage. Then we have to harvest the saphenous vein. Now, we did this in an earlier lecture, but this is an excision because we're taking out part of the vein, and what we're taking out here is the greater saphenous of the left leg. So we go to greater saphenous left, and the approach for that was percutaneous endoscopic, and there was no qualifier. So this is how we actually get to the code for harvesting of the greater saphenous. Now, the next root operation that we're going to look at is dilatation. And this is actually when we expand or we dilate an orifice or the lumen of a body part. And the lumen means the inside of the body part. And the intent of this procedure is to make it larger. And so they can accomplish this either within the lumen of the body part or outside the lumen of the body part, intraluminal or extraluminal. Now, if the dilatation's part is part of or it's the approach for another procedure and it's not the intent of the procedure, then it's not the root operation. Basically, it's not coded. And so an example of this is when they do a D&C, they have to dilate the cervix and to get access to the endometrium and extract it, and so that becomes part of the procedure. We don't code that separately. So some examples of a dilatation procedure are a PTCA, percutaneous transluminal coronary angioplasty, and we'll talk about that more when we're in, I think it's chapter 16. Esophageal dilatation. Sometimes patients have esophageal strictures, and so they actually go in and they dilate the esophagus. They may go in and dilate the common bile duct, or a patient may have a urethral stricture that they go in and dilate, or the patient may have an old anastomosis site that they need to go in and dilate. So we're going to look at coding a PTCA of the left anterior descending coronary artery and the insertion of a stent. And we'll cover this much more when we get to chapter 16. So in the index, let me just put in, okay. If I put PTCA in, it tells me to see dilatation, heart and great vessels, 027. And when I get to this table, you see I'm back at the body part table. I'm in the same, this table looks the same as it did for bypass, if you'll notice. And so when I'm looking at this, this procedure was actually performed on one artery. I can't actually go in here and choose the left anterior descending coronary artery, but I can choose coronary artery 1 artery. And the PTCA, this is percutaneous transluminal coronary angioplasty, so the approach becomes percutaneous. And then we put in a drug-eluting stent. And so that is intraluminal, and you can see that we have options here, intraluminal, drug-eluting, and then we have 2, 3, 4 or more. We also have, we distinguish between stents that are drug-eluting and they are not drug-eluting. And if the documentation doesn't tell you specifically that it's drug-eluting, you don't code it that way. But we know that we had a drug-eluting stent, and it was not at the bifurcation, so there was no qualifier. So our code is 027034Z. And so that is how we get to that code. Now, the next example is EGD with dilatation of a stricture at the esophagogastric junction. So here we're going to put in dilatation, dilation, and we are dilating the esophagogastric junction. So there it is. So 0D74 is the table, and this is via natural artificial opening endoscopic, and there's no device and there's no qualifier. So our code is 0D748ZZ. So next we're going to talk about the root operation occlusion, and this is when we completely close an orifice or a lumen of a tubular body part. The important term here is complete. Occlusion is complete. When we go down here and we look at restriction, that is only partial. You have to make sure you understand the difference in these. For instance, if a woman has a tubal ligation, we would completely occlude her fallopian tubes. We would never want to mistakenly restrict them because that would be like playing Russian roulette with whether or not she could get pregnant. When you have a tubal, you do not want any eggs to escape. Some examples are like a fallopian tube ligation. You can do ligation of a blood vessel. There are some embolization procedures where the intent is to totally occlude that body part. So you just have to read the operative report to determine whether or not they're doing an occlusion or a restriction. And of course the example they here have is a tubal ligation. And there's not one for tubal ligation, so we'll put ligation, and it tells us to see occlusion, and we can put fallopian tube, and you can see that there's a code for the right, a code for the left, and then a code for bilateral. There are some situations where women have had a fallopian tube removed for whatever reason, and they may only have one functioning fallopian tube, but if they have both fallopian tubes and it's a tubal ligation, it is definitely going to be fallopian tubes bilateral. And typically this is a percutaneous endoscopic procedure. Then we have the device, what type of device was used. There could be an extraluminal or an intraluminal device, or there could be no device. They could cut them and tie them, but usually they use clips, so that would be an extraluminal device. And so the code would depend on what type of device was used. And then the last root operation that we're going to look at here in your book is for restriction. And this is a partial closing of an orifice or the lumen of a body part. And a Nissen fundoplication, which is a fairly common procedure, patients that have GERD, sometimes they have to go, the stomach is going up into the esophagus, the stomach contents are going up in there, and so they go in and they tighten that up. So that is considered to be a restriction. That's a Nissen fundoplication. A gastric banding is an example, a cerclage, cervical cerclage. If they do clipping of a cerebral aneurysm or an aneurysm, a repair with a stent graft, those are examples of restrictions. And so in the index, let's go to restriction. And you can see that there are quite a few entries for restriction, so you need to be very specific about what we're doing, and we can look at the esophagogastric junction, 0 feet V4. Usually this would be via natural or artificial opening endoscopic. A lot of times there's no device. They are just suturing, and so that would be the code. In your textbook, we're doing a laparoscopic gastric banding with an extraluminal device. And that is actually performed on the stomach. So we would go to table 0DV, and we would be choosing 6 for stomach. And typically this is done percutaneous endoscopically, and there is an extraluminal device and there is no qualifier. And so that is how you would find that code. For this lecture, I want you to answer in exercise 8.5 on page 158. I want you to answer question number 3. So exercise 8.5 on page 158, question number 3. And that will conclude this lecture.